So I'll say that again. So we will, if you go to the recording on YouTube from the last time, you will get a lot of information about the network for Ecohealth and One Health and the history of that. And then you will also get a good overview of the reasoning behind the book, how we structured it, and how it all came about. So we're not going to talk about that again today. Today we are going really to focus on the different chapters. But before we do that, I just want to point out that our network for Ecohealth and One Health, which is very much a community of practice on One Health, we are working on different topics and have a website that you can visit. Is open for memberships. At the moment, we are not asking for membership fees. We have a little bit of a promotional offer at the moment. And so if you would like to join, you can go to the NEO website and you can see the link here. We can also put it in the chat and join us. And with that, I'm handing over to our first speaker, Maggie, who is going to talk about chapter 3. Maggie, over to you.
First of all, thank you, Barbara, for the kind introduction, and good morning, good evening, wherever you are. So I drew this. I have this opportunity to talk on behalf of this great team. It was to be working with Nicola, Luis Pedro Carmo, and Anais, multicultural, multidisciplinary team. And this is what we really aim for, is to really highlight that regardless of your background, we can start. So on a short note, I am both a human nurse and a veterinarian. I'm also trained in conservation biology.
Yeah. Can I ring you back in a bit?
I hope Andrea can also hear me.
On this webinar I'm on health. So, okay, can I call you back later? Yeah. Okay.
So let's just Andrea to be muted, and I'll continue. So as I was saying, I have a diverse background, and this background also reflects on the fact that I always wanted to practice One Health, Ecohealth, as Barbara was saying. And I was fortunate enough to meet NEO. I was accepted in NEO, and here is our output, one of our outputs. So Barbara, can I ask thank you so much. So this chapter is actually not as visual as other chapters. For instance, for the chapter 1 and 2, whoever was before has these chronological sets. It's very nice. Now, it's actually intended for this initial and to get you to entice you to go through the book. This chapter is a bit more, reading wise. You have to really get into it, because it's just by understanding and getting into the knowledge that we can actually then do the practice. The overview is very simple. So One Health was already introduced as a concept, the interactions, all the integrative approaches, most of the integrative approaches had already been sifted through in the first chapters. So we wanted really to dive into what is multidisciplinarity, transdisciplinarity. How are we going to make it operable, operationalize the concept in itself in these wicked problems. And above all, as Barbara was also highlighted, we really wanted to forge the path for the competences. It's not just One Health, it's about the competences that we need to apply for. Following, please. So this picture this depiction is not from our book. I used it. It's also available because Nicola actually has a fantastic visual setting of this kind of multidisciplinarity, interdisciplinarity, transdisciplinarity, but it's only a depiction. So as you go through it, you can acknowledge what it is and when is it put in practice and examples. We really forged our chapter on examples, not just blah, 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 this is this, and what is the meaning. Most importantly, we gave examples. So one can really understand when is it in place, okay? The most important thing was to recognize the collaborative efforts and the approaches, and in which one would it be most useful, okay? So identify the categories also because of this creative process. The following, please, Barbara. Everything comes together because when and why do we use this? And we actually went through the 5 W's, and I took the liberty to add the how, because the how comes back again to the epistemology. The epistemology, theory of knowledge. How does everything evolve? And we always talk, sorry, today it's still morning for me. I'm not fully burning my brain here, but the thing was, we have to step out of the theory, okay? We have to acknowledge what it is, and we know that problems worldwide are very, very complex. And we stepped from the disciplinarity in highly specialized fields that are also needed into the collaborative efforts in order to solve these kind of wicked problems, the very complex problems, where the concepts are very fuzzy. And we also go through the nomadic concepts, the traveling concept, that what it is for me in one term, what does it mean for a social scientist? I'm not a social scientist, but we apply the same kind of tools or the same kind of thinking in a different perspective. And this is what it is for. So problem solving, and above all, have a structured system thinking. It's not structured itself, it's to apply system thinking and design this kind of creativeness. So working in One Health, this is really reflective of what it is. Working in One Health, one will often face the issue of terms not being understood. Even more so, we talked about this in the previous webinar, because we are now all in English, but I saw Juan Garza is here. Good morning, well, good evening for you. Spanish talking, Portuguese talking, French talking. We all, our culture, our native tongue frames us, and how to harmonize and come together is it's really the issue, okay? So we would like to pick your brain. That is why this chapter travels with you to try and structure frameworks. Obviously, the frameworks are not fixed, set. You have to evolve. They are created by interactions and interactions with the kind of multidisciplinarity. Integrate knowledge, and this is the transcendent part, and always acknowledge the interconnectedness, okay? So who, what, which, where, when, why, and above all, how are we going to do this is the baseline. The following, please. So this is just one of the examples that is actually in this chapter. And above all, we also wanted to acknowledge the barriers. And this was very, very constraining, because the team was working, well, the book was a long journey for every one of us, for all of us. And we really had to acknowledge the barriers, because we face these kind of struggles. And why we are talking about Ecohealth, One Health for so long. And it's not a novel concept, but what is the struggle to implement it? This really, we wanted to really acknowledge which are the actors or which are the fields that we are not crossing. We always talk about disciplines, but pay attention. It's not disciplines in the scientific academic area. So it's more than fields of knowledge. And then we also categorized in this kind of stakeholders, the political stakeholders, the economical contributors, the scientific. And this was really acknowledging, we are tossing coins at each other because we want this kind of funding. And the funding is also not adjusted to the collaborative efforts. This is just one of the examples. I'm sure that all of you here have this kind of experience, sadly. But hopefully this is also changing, and we have recently we have had examples, fantastic examples. Also the ethical component. We really need to integrate the multidimensional fact that we are going through. So I think I'm extending myself. The following one, and then I'm just hushing. The next one, please, Barbara. And this was just a tiny enticement for you guys to see how everything goes. The examples, we have kind of examples, and to really pick your brain and to entice you to go forward and to implement what you read and you understand. Use this kind of knowledge, create. The creativity is the most important part. And we just wanted to say it's through role play, it's through examples, it's to some examples that we give you actually answers, and hope that you also can contribute with your own realities, because this is, we think globally, but the locality, implementing it in your own setting with your own tools is the most important thing. And I believe I'm about to wrap it all. The next one, please. So this is kind of the learning questions that we have and the additional activities. And I hope I enticed you to read this chapter. And I'll give the word to Martin. Thank you so much.
Good evening. I'm speaking to you from somewhere in the Pacific, and it's really late here. My name is Martin Hitziger. I'm environmental scientist and social scientist, and I present you our chapter on specifically one area of concepts around knowledge integration, which will sound very much social science for you, but maybe after this chapter, you agree that they are interesting and potentially important. I acknowledge my 3 co-authors who I think are not on the call today, but have also contributed to this chapter. Next slide, please. Chapter 4 introduces you to the idea and the challenges and methods and thoughts about how people can work together on a very fundamental level in terms of understanding in a profound way, bridging barriers that Maggie has just described, integrating very different kinds of knowledge in ways that are useful. And the chapter also introduces you to a couple of additional aspects that I have no time to go into here about how that relates to systems thinking and system science, to decision-making, and to, say, lengthy procedural chains of evolution in thought and knowledge and decision-making over time. Next slide, please. The key term that I really hope you have an idea and an opportunity to understand in these 10 minutes is knowledge integration. What does it mean? It has been defined as one of the 6 or so key challenges in public health for the 21st century. And I know there are a couple of different definitions. What we are using in the book and what I'm proposing you here is that it really means to weave different threads of thought together, to understand commonalities and differences and relationships of perspectives in a profound way, consciously, not just superficially. And maybe the 3 pictures on the side of this slide can illustrate some of those thoughts. You see a relatively more or less elaborate weaving of weavers in Guatemala. And you may come to think that actually all of these threads that are being woven together, they are all different, right? The patterns, the colors, and the structural patterns of the weaving are not in any of the threads. It's how you put them together. And you can put them together in many very different ways, but only some of them make sense so that you get a good piece of cloth that looks also beautiful and that is obviously built from, emergent from the original threads, but much more and very different from each individual thread that was before. So if you think of all the different contributions of people in One Health as a thread and weaving those together in a way that is useful for public health, then you can use this metaphor for understanding what knowledge integration tries to achieve. There are 3 different forms of knowledge or kinds of knowledge that are all affected and should all be considered in weaving those contributions in One Health together. One of them is systems knowledge, and that may be closest to what you would typically understand to be knowledge. It's factual knowledge about reality that operates in certain ways. It can be broken down most of the time. It can be physical, biological, chemical knowledge. It's what science usually concerns itself with, and most scientists would be happy to consider that knowledge in one way or the other. There's a second form of knowledge, which we call target knowledge, which is more concerned with what you actually want to achieve. Not all scientists would usually think that's knowledge. They would consider that to be values or something else. But if you think of it as something that you want to achieve because of some reason, because of a factual situation, because coronavirus will otherwise kill us all, or because of some public health evidence, then you come closer to understand why target knowledge is actually a form of knowledge. And goals and objectives are being built based on your knowledge rather than just being there completely independent of systems knowledge. There's a third form of knowledge that is particularly relevant in One Health and in practical problems and for decision-making when it comes to transformation knowledge, which essentially is your knowledge of knowing how you can achieve your goals based on your understanding of the system. So that's about the machinery, that's about strategies, that's about procedures, that's about steps, milestones, and etc. And all of those three are relevant and important for integrating contributions, knowledge of different practitioners in One Health. Next slide, please. One step back and one step deeper, also think what knowledge means. So this is getting farther into the questions, what actually are we trying to integrate in One Health? And I offer you a very anthropological concept of what knowledge is, and it's explicitly more than just factual knowledge that's proven by science. So if you think of yourself as someone who makes your way in your life, trying to achieve goals that have a justification and some understanding of your context, of your system, all of what you use to decide on your next steps are your knowledge. Your knowledge of what you want to achieve, your knowledge of how you do that, your knowledge of how the system works in which you want to achieve something. That includes your feelings because they influence what you want to achieve. You react intuitively to certain situations with attraction, repellent, with fear, with all sorts of emotions. And they influence how you behave and navigate in your system. Information, you will agree that's part of what science deals with. Embodied skills is not so obvious. These can be artistic skills, it can be crafting skills, it can be the little experiential kinds of behavior that, say, a surgeon uses when doing an operation. It can be verbal taxonomies that you never really think of much because you always knew that a cat is different from a dog, but in what form are they actually different? In what form are they similar? And in what form is maybe a dog more similar to, say, a robot than a cat is? You could ask these questions and you could come up with some thoughts about it, and that is knowledge. The ways you structure your knowledge essentially in silos, in categories. And I would like to especially emphasize one that is relevant politically at the moment, but also not very recognized in science usually. Knowledge of people in the anthropological conceptualization includes whatever judgment they consider truthful based on whatever criterion they use, because it is what steers their choices. And it's their knowledge that steers their choices. And that includes what others whom they trust tell them they believe. You have to read this again. Think about it twice. I give you 5 seconds and then please next slide. On this slide, I refer to one of our boxes, applied examples. If you were attentive on the previous slide, you saw 2 pictures. Both of them relate to venues in which knowledge is being integrated. One of them was a UN conference in which very different stakeholders come together on very elaborate procedures and rules to essentially integrate knowledge to come to a joint resolution that is then hopefully put into practice as agreed by the United Nations. This box relates to a study that I was involved in coordinating in Guatemala to build a structure in which traditional and Western doctors would be able to communicate and do first tentative steps towards an integrative health service system in Guatemala. So we tried to build a structure based on trust and communication and specific methods and procedures in which the very different concepts of health and disease, the different concepts of classifications of diseases, the different emotions that Mayan and Western doctors have towards each other in a country like Guatemala can be exchanged and shared and partially led towards a meaningful synthesis that is of use to patients. And how tensions that do arise can be addressed as a model for others to learn from, or as a model for others to improve what we are doing. And in the end, what is needed is to make a collaboration like that, whether that's in a real One Health setting, in a scientific study, or at United Nations or elsewhere. It needs to be salient for all of them. If they think it's not relevant, then you have already lost your cause, because the good people you want to work with, they are all busy and they all have other things that they do think are relevant to do. So you need to find ways to make sure that what you're doing is relevant to all of them in their own terms, in their own knowledge. They need to come to the conclusion that that is relevant. It needs to also be credible. And that's already a challenge between scientific disciplines. It's more of a challenge if it crosses the boundaries between, say, the rather STEM science subjects and the more humanities subjects. It's even more difficult if it goes into decision maker scenes, into politics, and worse if it goes into like divided societies in which people trust whoever someone else tells them they believe. Huh? And the third challenge is everyone to a certain degree needs to consider it legitimate. They need to understand or believe and come to the conclusion that what you are proposing is respectful, is in line with their general procedure, in line with their general hierarchies, in line and fair of how it treats their views and others' views. And all of those three are competitive. They're competing. You can't always achieve all of them very well. Even worse is it when you try to achieve all of those three in the perspective of very different people at the same time. So this is brinkmanship. And knowledge integration essentially is a piece of brinkmanship to try to weave together perspectives, given a couple of circumstances, given a couple of limitations, given a couple of constraints, into a piece of cloth, a piece of joint understanding of common knowledge in which the perspectives contribute, make sense, build a larger picture that has not been there before, an emergent understanding. And that is quite a challenge. And this chapter tries to help you with this. Next slide, please. And as my last slide before I hand over to John, what will you practically learn? You will learn basic concepts that a few of them I have explained to you. You will also see a couple of more practical examples, how that has been implemented, a few more practical steps of how to make it happen, literature reviews or literature sources where you can learn more. You will be able to recognize some basic characteristics and reflect on them in your One Health work or daily life. But in particular, I think the aspect in the chapter that we are most proud of is actually a sixth one. It's a relatively large set of reflexive exercises and learning questions to reflect on these concepts in very practical, simple daily situations, which is not an academic requirement. It's not an analytic skill. It's more of an expanding of your perceptiveness and awareness of the challenges that limit knowledge integration in One Health. And we believe that if you follow interested in these reflective exercises and keep doing them, keep thinking about them, and keep applying them in your practical professional life, that it will help you refine your intuition and analysis of One Health challenges to sharpen your judgment of what actually is the problem that you're dealing with and how can you address it. By doing that, they will improve your professional track record. We think they will also deepen your wisdom. And over time, it may become a habit and a character trait. And we wish you all the best on that journey and hope you enjoy it. And I hand over to John. Thank you very much.
John, we cannot hear you. I think you need to unmute yourself.
Sorry about that. I still make that mistake. So my name is John Berezowski. I'm a veterinarian. I spent close to 20 years in food animal practice in Canada, and then decided to take a journey into epidemiology. So I did that, and then I've been working mostly in surveillance, disease surveillance. I'd like to say health surveillance, but not that much. In animals, people, and not so much in the environment. So from that perspective, myself and my co-authors, Louis Carmo, Craig Stephen, and Laura Falzone, were looking at One Health from this perspective of data, information, knowledge, and wisdom. And that's mainly because it comes out of the surveillance field, where we recognize that surveillance produces information, and then we try to understand how surveillance can provide benefits by looking at what that information is used for as we move towards controlling diseases or mitigating their effects. So next slide, please. So we start with some challenges. And the first one is disease X. So in 2023, the WHO listed disease X as a priority, and it was a challenge for us, especially those of us in surveillance. So disease X is just a syndrome. It's just a definition, a previously unknown, rapidly spreading disease. So we challenge the readers of our chapter to think about, if a new disease appeared, what would you need if you were in charge to decide if it was the next disease X? So next slide, please. So we're going to try to help a little bit with that, but that's still a difficult problem. So we also present this challenge about the complexity of health problems. So this one is about the reemergence of leptospirosis in tropical countries. Of course, you know, leptospirosis is a bacterial disease, affects many species, including humans. It's spread in the urine. In urban settings, rats are a reservoir and part of the transmission cycle. The pathogen can survive for months and years in soil and water. And infection occurs from soil, from water, from urine, or contaminated food. So we can look at this disease, and we're going to try to do something about it from a number of different perspectives or a number of different lenses. So we could consider it to be a problem of climate change, because increased rainfall causes increased flooding, and that's been associated with outbreaks. In tropical countries, there's often no infrastructure to prevent flooding. And so it is a problem of infrastructure, and it's a problem of climate change. It's also a problem of poverty, because in many cities, in the poorer regions of the cities, in the tropics, there's poor sanitation, no clean water, and often no health care. So it is a problem of poverty, and we probably can't solve this problem until we do something about poverty. It's also a biomedical problem. Leptospirosis presents with many different clinical manifestations. It's difficult for physicians to diagnose. There are no really good clinical tests for it right now, and there is no vaccine. So it's a biomedical problem. It's a technological problem. We may not be able to solve this problem until we deal with some of those issues. And it's also a problem of rodent control, because rats are a reservoir and they are involved in transmission. But we know from many studies that our traditional approach of attacking the rats doesn't work. So we need to understand rats better, and we need to develop new ways of managing rats as a reservoir. So next slide, please. So we approached this chapter as from a kind of a practical perspective, where we consider the practice of One Health to be a decision-making process. Now, this doesn't really conflict with any of the other approaches to One Health in the book. I think one of the strengths of this book is that we have many different perspectives and many different ways of looking at One Health. So we looked at it from this perspective of a decision-making process where we attempt to implement solutions that optimize the health for people, animals, and the environment. And there's lots of different decision-making paradigms or frameworks. This is one we created because it works particularly well with this data, information, and knowledge and wisdom framework. So it's a series of questions, and each question actually represents a decision. So is there a problem? Is there a problem that we need to do something about? Is an action needed? What are practical solutions? What's the best solution? And then if we implement that solution, we need to know whether it was effective or not. So all of these are decisions that have to be made at different points. And we were thinking about what are the inputs are needed to be effective from a One Health perspective at each of these points. So next slide, please. So we borrowed the data, information, knowledge, and wisdom framework. You'll find it in a lot of places in the literature. What worked for us was one that came out of engineering, actually, and an engineering approach to trying to understand risks associated with civil engineering. If we build this bridge using these materials, and these methods, how long will that bridge last? What is the risk that it will tumble if there is an earthquake? So this paradigm considers that there is a lot of data, and this representation here in this graph on the y-axis is increasing human input, and on the x-axis is increasing complexity. So it illustrates a few points. One is that data, information, knowledge, and wisdom are not mutually exclusive. The definitions are not great, and there is overlap between them. We consider that there's more data than there is information, than there is knowledge, than there is wisdom, and that as we go from data to information, knowledge, and wisdom, human input increases and complexity increases as well. So next slide, please. So in the book, we go through what is data, what is information, what is knowledge and wisdom. So I'm not going to go through them in depth here, just to say briefly that data is really a collection of symbols, and in itself has limited value. Next slide, please. It is only when we start to organize data and structure it, analyze it, and interpret it that we turn it into information. And it's at that point when it starts to become useful. And the usefulness comes out of the questions that it can answer. So for instance, in health, one of the most basic questions we'd be thinking about is, how much disease is there in this particular species, in this particular location? And is it increasing or not? So next slide, please. Information then contributes to knowledge, and we don't really go into the depth that Martin went into in his chapter about knowledge, but I think the thing to say is that knowledge is created by people, so it's contained within people. And that's called tacit knowledge. We also export it into books and into newspapers, into web pages, on television, on the news, and all kinds of different places. And that's called explicit knowledge. Why tacit knowledge is so important is that we learn from books and we learn from teaching, but when we're solving problems, often, especially complex problems like the ones we talked about in the beginning, we don't have enough knowledge. So as Martin talked about, we have to think about where we can get local knowledge and indigenous knowledge and knowledge that's grained from outside of science. Next slide, please. Oh, before we go, knowledge, you don't have to go back, Barbara, but in my example of where information might be related to there's an increase in the amount of disease, then knowledge would answer the question, is that important or not? And should we do something about it? So next slide, please. Wisdom is the most difficult to define. It's more than accumulated knowledge and information and data. It brings in judgment, experience, intelligence, cognition, values, and many more things. And we are presenting wisdom as being able to, once we have identified that there is a problem and that it's important through knowledge, then wisdom would be to know what is the best solution in terms of being optimal for people, animals, and the environment. And then also other things such as most effective, cost effective, minimum unwanted negative outcomes, and of course, optimizing health of people and animals in the environment. And the basis of One Health, I think, is that one person cannot contain enough knowledge or wisdom to be able to solve these complex problems. So where One Health came from was recognizing that all of these healths were integrated and that we had to incorporate knowledge and wisdoms from multiple people, from multiple backgrounds, if we're going to come up with good solutions. Next slide, please. So that's the the knowledge, the data, information, knowledge, and wisdom framework. Then we present 3 case studies. The first one is about surveillance, and we looked at how surveillance provides information and where we get the knowledge and wisdom needed to make the decisions about each one of these steps that I talked about in one of my earlier slides. So how do we use this to make decisions? Next slide, please. And the second case study was about climate change. And in that case study, we develop a framework for evidence-based decision-making that also works through a number of questions. And we ask things like, is there a knowledge gap? Does that knowledge gap impede action? Yes or no? So it's an algorithm to help you think about what is needed for in terms of knowledge and wisdom and information to come up with an evidence-based action. Next slide, please. And our final case study was about, so we've talked about data, information, and knowledge and wisdom, was about what happens when we have too much information. We're in this age where we're bombarded through social media, through television, through newspapers with all kinds of different information. And based on learnings from COVID-19, we talk about how having too much information or having information that is not valid, not credible, can affect how we make decisions both personally and as a society. And that's my last slide, Barbara. So thank you.